In this episode, we will give you a basic understanding of how evidence is gathered and ranked by doctors. This will help you understand how doctors think, which in turn will highlight why it is important you think for yourself. There are 3 main points in this episode. First, most doctors and healthcare systems require what is known as Level 1 evidence before making a recommendation to patients. Second, at Curve, we think it's important to take a broader view of the evidence and consider all levels of evidence. Third, it's important to tread carefully when looking at lower-level evidence as there are problems with it. We want to empower you to help yourself. So, let's begin. Broadly speaking, medical evidence can be split into levels or tiers. The RCT, also known as the double-blind, placebo-controlled trial, is considered the Rolls-Royce of medical trials. Here, the patients are randomly assigned to 2 groups, one of which gets the actual treatment, the other a placebo. Neither the doctors administering the treatment nor the patients know who is getting what, hence the name double-blind. This is Level 1 evidence, and is what most doctors and healthcare systems look for before giving advice. This is because it shows causation. It is the only level of evidence that conclusively shows when one thing causes another to happen in humans. This process works brilliantly when testing new drugs. However, the way these studies are designed means that they are difficult to apply to lifestyle interventions. For example, it is virtually impossible to blind lifestyle interventions. People prescribed a specific diet, for example, will know as much because they are eating the foods rather than swallowing a nondescript pill. This means that any positive impact could actually be caused by a placebo effect rather than the diet itself. Likewise, those exercising clearly know they're exercising. Another problem is that RCTs are typically run over short periods, whereas lifestyle benefits, or complications, often manifest over much longer periods, years or even decades. In short, RCTs are difficult and expensive to apply to lifestyle interventions and receive little funding compared to drugs. But what about Level 2 and 3 evidence, cohort and case control studies? These are both types of observational studies, whereby one group is observed over time and compared to another. The differences between the two are beyond the scope of this introductory video series. An example of these types of study would be to take a group of breast cancer patients and track them over time. The group would be split into 2. One asked to follow a specific diet, thought to help prevent the recurrence of breast cancer. The other continuing to eat the standard American diet. It would then be possible to see whether there is any correlation between those who eat the prescribed diet and those who have lower rates of cancer recurrence. But there are problems with cohort and case control studies. For example, there is normally no randomization and no blind testing. Also, those being studied are often asked to self-report their progress. And we know that people have bad memories and worse, sometimes lie, particularly when they should have been eating a certain diet, but haven't been. So, there are valid criticisms of these types of studies, and while steps can be taken to reduce the risk of bias, it cannot be eliminated. Perhaps, most importantly, these studies only ever show correlation, not causation, and this is a fundamental problem that plagues nutrition science. Correlation does not equal causation. Inferring causation from correlation can lead to significant errors. In fact, the problems associated with Level 2 and 3 evidence are so great that many doctors and scientists dismiss them as untrustworthy. It's understandable. They want to wait for more concrete evidence. But this doesn't work very well for cancer patients, as they don't have the luxury of time. They need to make decisions based on limited and imperfect information. If they don't, they risk not doing things that could really help. Also, given the inherent limitations of applying RCTs to lifestyle interventions and the lack of funding in this area, there may never be solid RCT evidence showing the benefit of lifestyle in cancer. This is relevant because, as we now know, most doctors and public health systems look primarily to RCTs when making recommendations. Hence, in our view, lifestyle advice is not often given the prominence it deserves. But why? Well, as mentioned earlier, doctors require high levels of certainty before making a recommendation, and it can be hard to obtain this for lifestyle interventions. Also, the time doctors can offer each patient is limited, and normally there's already a lot to cover. Another reason is that most medical schools teach little to nothing about nutrition, despite it playing a key role in many of the chronic diseases that plague our society. Most doctors know very little about nutrition. Yep, you heard that right. Nutrition's fundamental importance in healthcare is only now being fully appreciated, and it seems medical schools have some catching up to do. This means the cards are stacked against revealing the scientific prominence lifestyle deserves in cancer treatment. This is a systemic issue, and it's a problem. It's also all the more reason you need to get involved and think for yourself. Our view is that lower-level evidence must be considered, but treated with some caution. Indeed, given the limitations inherent in RCTs, it would be irrational to insist on them as the only basis for considering how to approach cancer. At Curve, we fully accept that lower-level evidence suffers from multiple problems and is therefore risky to rely on. But we think the risk of ignoring it, and thereby possibly foregoing things that might make a real difference, is far greater.